All right, good morning, everybody. Welcome to Medicine Grand Rounds. Today, I have the ultimate pleasure of introducing to you Dr. Kelley Branch. Dr. Branch received his Bachelor's of Science at UCLA and secondly, his medical degree at Jefferson Medical College. He then traveled to the University of Michigan, where he completed his internal medicine residency, and finally made his way to Seattle for his fellowship in cardiovascular disease, supplemented by a master's in epidemiology. Dr. Branch is currently assistant professor in the Division of Cardiology, medical director of the General Inpatient Cardiology at the University of Washington, and associate director of the Clinical Trials Service Unit. Dr. Branch remains very active in patient care, being my attending on wards just 6 months ago, and is known amongst the residents for his excitement with teaching and his superb bedside learning. Dr. Branch has publications that are vast, expanding, well over 100 of peer review articles, abstracts, and reviews. And moving on to his awards, he has been awarded the Cardiology Teaching Excellence Award, the Emerging Clinical Faculty Award from the American College of Cardiology, and Fellow of the American College of Cardiology. Most recently, Dr. Branch has been awarded the University of Washington and University of Queensland Trans-Pacific Fellowship, and he is here today to give us his grand rounds, the new anticoagulants in cardiovascular disease, atrial fibrillation, and beyond.
I hope this is recorded. My mother would be so proud. So thank you for that very kind introduction. So I'm going to take, this is a little bit of a detour from what I typically do. As many of you know, I'm one of the imaging guys, that really annoying cardiac CT guy that always seems to be dragging people down to the CT scanner. But one of the things in the Clinical Trials Service Unit, we're actually taking a look at some of these novel anticoagulants within a large international clinical trials. And so because of this, I thought, what a great way to orient myself and to make me suffer and build 120 slides on the new anticoagulants in cardiovascular disease, such that you get to share in my experience, my learning also. We will go through this. And there's probably some additional expertise here. There's no hubris on this side of the podium. If anyone has any comments at the end, then I'll be happy to listen to you and learn from you also. So my disclosure slides, really nothing to disclose at this point. So we're going to do a couple things. We're going to start off with a quick review of atrial fibrillation. A lot of this will be reviewed for you. But just to emphasize some of the things that, as a cardiologist, once they broach and come to the cardiology clinic and they see a bunch of people walking around with hearts on their white coats, what are we thinking about? And then moving into really focusing on thromboembolism and talking about really what the standard of care is now, and then moving more specifically into the novel anticoagulants, talking about the pharmacology, the data behind them, now that we have a third option with Apixaban recently becoming FDA approved. Finally, we'll talk about some special circumstances and then some of the future directions as we move forward. So thinking about the prevalence of atrial fibrillation, it's not only common, it's really common. And it's going to become commoner as we move along. And if we're looking at what's going to happen, the dashed line you see is the here and now, and take a look at what's going to happen with atrial fibrillation as we move along. By far the most common electrical problem that we see as cardiologists, and we are going to be looking at between now and 2050 anywhere between a 2.5 to 3-fold increase in the number of patients with atrial fibrillation, such that this will become much more of a prevalent disease for us, if we can believe that, and even a more prevalent disease for the people in the audience also. And when we think about atrial fibrillation, we really think about it in two very separate ways, at least I do. And I talk about the two silos or the two pillars of atrial fibrillation management. And these should, I think, be separate in everybody's mind. One of which is the rate and rhythm control. That is an entire hour topic upon itself. But really what we're going to be focusing on is the prevention of thrombotic complications. And if you separate those out in your mind, it gets a little bit easier to approach your patient because you're going to be talking about two very separate things. Well, why do we really care about atrial fibrillation that much? Is thromboembolism really that bad? Well, the problem is, yes, it is. Yeah, okay. But here's some data to prove that it is. Okay. I don't know, who's buried in grants too? But if you look at, comparatively speaking, as far as thromboembolism and atrial fibrillation, if you look at stroke from, say, carotid disease or some other source versus atrial fibrillation, the strokes that occur from atrial fibrillation tend to be larger, they tend to have a higher mortality, and they tend to have a more severe, more common and severe hemorrhagic transformation. And a lot of this has to do with just the sheer clot burden. I mean, it's a bigger clot. It comes from the, it's a nice little cast of the left atrial appendage that decides to fly up into the brain. That's a bad thing, rather than something that's going to be relatively small and maybe more platelets, you know, flicking on. So this is bad. So obviously trying to prevent this becomes very important, and hence we talk about anticoagulation. Well, we can't talk about anticoagulation without really considering that there are really two tenets to this, and these really are on a balance. And the balance is, depending on how thick or thin your fulcrum is, that we really are trying to prevent thromboembolism and at the same time balance against bleeding. We do not have a left atrial appendage or left atrial or anticoagulation agent. It just doesn't happen. It has to be systemic anticoagulation. So because of that, we're constantly having this balance between the two. And as we move forward, one of the ways that we figure out how to treat our patients, obviously, is risk analysis. And we're going to talk to you about things you already know and some of the things maybe you haven't used very much but are really coming into clinical practice as we move forward. So, of course, one of the first things we do is risk analysis, and then we'll talk a little bit about the appropriate therapies for really the standard of care right now. So, anybody ever heard of a CHADS-2 score? Yeah, okay. Obviously, CHADS-2 and CHADS-2 VASC have really, I think, penetrated very well into what we do every day. And for many of our patients, you know, I'm constantly railing on the fellows. I said, you need to write down what the risk is. Okay, just like the Framingham risk score. Sometimes it's good to quantitate these things, okay? So we really, and looking at how well this works, you know, Dr. Lipp has done so much work on this and continues to, looking at the relative stroke risk as the CHADS-2 goes up or the CHADS-2 VASC goes up. It really does a good job of telling us what our relative risk is. So one of the things that we talk about is that you should have some type of documentation within the patient chart saying what is the risk. And the CHADS-2 is relatively easy, CHADS-2 VASC is relatively easy. The CHADS-2 VASC is really helpful for that gray area of those patients that are in that intermediate risk, CHADS-2 risk of 1, CHADS-2 risk of 0, but maybe they're not quite at the age of 75, they're not quite at the age breakoff. And so you're trying to figure out, are they low risk or are they maybe heading into that low intermediate risk? But right now, if you look at the ACC-AHA guidelines, they haven't quite caught up yet. The European guidelines have, but the ACC-AHA guidelines have not, such that we're still looking at these mild risk factors, moderate risk factors, and high risk factors and having recommended therapy based on them. Many people have extrapolated that the risk categories would be no risk factors would be a CHADS-2 or CHADS-2 VASC score of 0. One moderate risk factor would be a CHADS-2 of 1 or CHADS-2 VASC of 1 or 2, then high risk would be CHADS-2 of 2 or higher. And these are the recommended therapies. And you'll see in the moderate risk, we have a choice. Aspirin or warfarin. What are most of our patients going to prefer, right? So it makes a little bit of a challenge for us, even though we know the patients are at slightly higher risk, and we can't tell whether or not the patients are going to be within that 98% that don't have a stroke or the 2% that year. And so we would like to drill down on this a little bit more. I did highlight the high risk factors of mitral stenosis and prosthetic heart valves, and the reason why is because if you look at patients with mitral stenosis, those are the valvular atrial fibrillation. The stroke risk with that one, 35% per year, every year. Doesn't take a lot of math to figure out that those patients are probably with stroke, right? So a lot of those particular patients have been excluded from the trials that we're going to see subsequent here. Okay, we really are looking primarily at the patients with mild to moderate risk factors. One of the things you may not be aware of are that there are bleeding risk scores out there. And there are a couple different ones. I show something called the HAS-BLED score, but there are other, there's Atrial and a couple of others that are currently being validated. But this is the one that the ACCHA currently recommends. And the HAS-BLED bleeding risk score, easily found online, easily found, of course, on an iPhone near you. And so it, very similar to the CHAD score, this is what you get. And so once you get this, these scores, you just add them up. And then you look at the number of bleeds per patient years. Now you see on this initial cohort that we really don't have a lot in the very high risk categories of 7, 8, or 9. But it is relatively easy to see that, that as the HAS-BLED score goes up, your risk of bleeding goes up significantly. And so the balance of what is my patient risk of stroke and what is my patient risk of bleeding can actually now be quantitated to some extent. And again, this and others are undergoing validation. We should have more data actually within the next year or two. So to summarize very briefly, just with the stroke risk summary, everybody needs a stroke risk assessment of some type. We suggest, of course, CHADS-2 or CHADS-2 VAS. There are some other scores that are out there now, which now include renal function. So there's the R2, CHADS-2, just to make it more complicated. We'll see how many more. This is going to become an alphabet soup after a while. It's going to be about this long. But at some point, we will be able to drill down on these patients even better. Right now, aspirin is reasonable for those patients that are CHADS-0 or CHADS-1 and CHADS-2 VAS score 0 to 2. And then oral anticoagulation, and most specifically where we live, Warfarin is considered for the CHADS-2 of 2 or greater and the CHADS-2 VAS of greater than 2. Bleeding risk can be assessed. Bleeding risk can be assessed, and is probably something that is going to be heading into a clinical chart near you. But again, I think more validation has to be done. But a lot of it right now is clinical judgment. Remember the HAS-BLED, nobody saw anything, it's not the HAS-BLED F, right, with the fall risk. That wasn't in there. Frailty index, that wasn't in there. So there's still a clinical judgment which has to enter in regardless of what you're seeing as far as bleeding risk. Let's take a look a little bit at the data here as far as aspirin, warfarin, and the combinations, and about what we would like. This would be ideal. This is what we would love. We have the dose and concentration or intensity of anticoagulation along the x-axis. The y-axis is thrombosis and bleeding, relative instances. You can see that there's these J-shaped curves, right, which are going in opposite directions. And ideally, we would have something that would have a huge safe therapeutic range, where thrombosis is minimized as well as bleeding. This would be ideal. We don't have this. We would like it to, but we don't, and I'll show you really where we are. But using what we have right now, using the tools that we have right now, if we use antiplatelet drugs versus nothing, or we couple that with dual antiplatelet drugs versus anticoagulation, and then if we compare this with warfarin, we can see that as we increase the amount of anticoagulation, as we go up the degree of anticoagulation, our stroke risk goes down and down and down. And this is really for all comers. But suffice to say that it really doesn't matter what your CHADS-2 score is. Your risk goes down substantially. It's just that sometimes we can get away with aspirin. But most people, even with the low CHADS-2 scores, would do better with full anticoagulation. Now here's the warfarin love and hate, right? We have warfarin. It works very well. It's been around forever, but there are some substantial problems. Things like, people that eat a bowl of kale. I'm not sure who actually does that. But if you did, suffice to say that you would be affecting your INR substantially. Broccoli, probably a little bit more common. Obviously, there's monitoring that can go on. We see a point-of-care device here, but that's not typically how we do it. You're dragging patients in to get another blood draw, and goodness forbid that their INR should be off, and they have to come in for those weekly INRs while you figure out what they ate. They go on a trip, and suddenly the food changes. Obviously, there's untold problems, and there is still a stigmata associated with warfarin because it is Coumadin, although it's Coumarin if you go to your neighborhood store to try to eradicate whatever pest happens to be living in your basement. And so if you look at the reality of where we are, instead of having that large therapeutic window, we really have a relatively small therapeutic window. And so if you look at the odds ratios compared to the INR, if you look at stroke, yes, indeed, we do a good job of decreasing stroke. Great job of decreasing stroke once we get that INR greater than 2. But if you look at the risk of intracranial bleed, you can see that that goes up rather nicely. And so here's our therapeutic range. Not quite where we want to be, but this is where we live. And so this is one of the significant problems with warfarin, is that it's such a narrow window that we don't do very well. So let's take a look at some data from reality rather than taking a look at the trials. And the reality is that if we look at the time in therapeutic range, and that is how many times are patients within their goal, INR, of generally 2 to 3, most patients are 2 to 3, how many times does this happen? This is a meta-analysis from the Journal of Managed Care Pharmacology, which I'm sure all of you have on your bookshelves. But suffice to say that looking at community-based as well as clinic-based warfarin dosing, if you look at this, there are only about 55% of the INRs that are actually within the therapeutic range as you look over a long period of time. That's only 55% of the time. So that means nearly 1 in 2 are not at goal every time you take an INR. Okay? This isn't good. And the reason why it's not good is for 2 reasons, right? You're either over or you're under. If you're under, you're not prophylaxed for stroke. If you're over, you're at a slightly higher risk for bleeding. So this imbalance is really the reason why we need to be doing something else, such as the novel anticoagulant. But does it really matter? Does it really matter? Is there really, if there's these subtleties, so it's 3.2. Does that matter if it's 1.8? Does that really matter with an INR? Well, if you look at the survival based on the TTR, and you get these kind of survival curves, you can see that those patients that are within the therapeutic range most consistently do the best. Okay, there's lots of bias that goes into these data, right? Because maybe these patients are more compliant, they are more stable with their food, etc. But if you look at the patients that are the least number of times in the therapeutic range, that's 0 to 40, and that's what we showed down at the bottom here, they actually do worse than those patients who are not on warfarin at all. So the worst adherers are the patients that are doing worse to stay in the therapeutic range, actually do the worst. And that's probably not too surprising to some extent. What about adherence? What about adherence to guidelines? How do we do? This is our report card. And our report card is actually not very good. And so if we looked at the risk level, okay, many different ways. This happens to be the ACCP risk level. Low, intermediate, and high for the first 3, and then the overall on the far right. Taking a look, warfarin alone is in blue. Warfarin and aspirin are in, in kind of that gray area. Aspirin alone is in the blue, and then no therapy is in yellow. And so as we move from low to high, you see that things change, but not really. The proportion of patients that are either not on therapy or the proportion of patients that are on really not appropriate therapy, either warfarin for those very low-risk patients, or I think more concerning are the high-risk patients, many of which are only getting aspirin or no therapy, is a little bit concerning. Now, there can be various reasons for this, obviously. There are some patients that just, because of fall risk, because of frailty, etc., shouldn't be on this. But it is concerning that we have a drug that we're concerned enough about that we can't get our patients to what they really need, which is full anticoagulation when they're at the highest risk for stroke. And so just as a quick summary, remember the current guidelines are that low risk is aspirin right now, low to intermediate risk is your choice, and then once you move up into the moderate to the high risk, then it's warfarin. Stroke risk is lowered significantly with anticoagulation or antiplatelet therapy, although if you take all comers, patients do better with oral anticoagulation. However, there's really kind of a modest use of appropriate anticoagulation and relatively poor adherence, data that were not shown here today, and almost 50% of INR samples were not within the goal. That makes it a coin flip. So there really can be some improvement as far as our treatment of patients. So hence we go into the novel anticoagulants. So here's some of the new anticoagulants. So we really have a couple kids to take a look at. 3 of which have been FDA approved as of now. and 2 more of which are in phase 2, heading into phase 3 trials. So the 3 I'm going to be talking about are dabigatran or dabigatran. By the way, you can use those interchangeably. I asked the rep. I said, what is it? I sound like an idiot. It's going to be Dabby from here on. But it really doesn't matter. Depends on whether or not you're in Europe or here. You can use either. Or Apixaban and rivaroxaban. Really, those are the big 3 we're going to be talking about. And if you look at some of the characteristics, this is an important slide because it really gives you a kind of an overview about what some of the pharmacology is. So the mechanism of action, dabigatran or Dabi, is completely different because it's a direct thrombin inhibitor. All of the other ones that are under investigation right now are factor Xa inhibitors. And so you can see some of the subtleties to this. You look at the half-life. Dabi tends to be a little bit longer than the others. Rivaroxaban tends to be a little bit on the shorter side. Interestingly, the regimens right now are BID, rivaroxaban with the shortest half-life is QD, although all of the studies that are currently ongoing with rivaroxaban are actually BID, and I have a feeling that's going to change. We shall see. Take a look at the time to peak. Time to peak. Anyone who's ever had to go into the patient's room for the 5th day and say, I'm sorry, your INR is not quite therapeutic, knows the suffering that warfarin can do for your poor patients, right? They run out of videos. So giving the medication, the time to peak is measured within hours. And so you can become fully anticoagulated really within a relatively short period of time, rather than waiting for the vitamin K antagonist to build up. As far as excretion goes, all of these are primarily renally excreted. And so renal dysfunction and relative renal insufficiency become a bit of an issue as we move forward. As far as metabolism and uptake, Dabi is a little bit different because it's only affected by P-glycoproteins, whereas rivaroxaban and Apixaban, including the other oxabans coming out, are actually affected by the CYP3A4 primarily, although there is also some other cytochromes which are affected. So we're going to talk first about Dabi. As a direct thrombin inhibitor, it does 2 things. It binds the free thrombin, but also binds the thrombin that is within clot. This is good and bad, and we'll talk about the bad later. But it is rather specific. It is a prodrug, and it does require an acidic environment, such that if you are taking very, very high doses of proton pump inhibitor and it does not encounter specifically an acidic environment, the levels can drop as much as 45%. Currently, there's no black box warning right now as far as the use of PPIs, but it's something to be considered. Peak effect is in 1 hour. Half-life we've seen is eliminated in urine, but no CYP metabolism, so the drug-drug interactions are substantially less for this particular drug. Dosing is 150 milligrams per day, unless you have renal impairment, and right now the FDA says for the creatinine clearance of 15 to 30, you use 75 milligrams twice a day. The problem with this is that 75 milligrams has actually never, ever been tested in a clinical trial. 110 milligrams was really where the non-inferiority comes. We'll see a little bit of that data, but not much. 75 milligrams is an extrapolation based on the pharmacokinetics that it seems to be reasonable that that's what we should be dosing. But note that only the 150 has really been tested in a trial. Let's talk briefly about the RELY study. And the RELY study is about 18,000 patients randomized to dabigatran 110, dabigatran 150, and then warfarin, really standard of care. This was a little bit different. This is not a randomized controlled trial. This is something called a probe design. And so the warfarin was an open label. The Dabi was not, although you couldn't tell what you were on. So you can tell was 110 or 150. So I tried for about 2 years. The primary endpoint, which is going to be you're going to see this again and again with all of these trials, the primary endpoint is stroke, that's thrombotic or hemorrhagic, either or, and systemic embolization with a safety point of major bleeding. This is going to become a kind of a broken record as we move along, published in the New England Journal. This was powered to be non-inferiority to warfarin, and again was non-blinded. About 50% were warfarin naive, never seen it before, and most of the patients completed the study with a pretty good adherence, about 78%. That's really quite good. The time in the therapeutic range, I made a big deal about that previously, right, was actually pretty darn good for a trial, which was about 64%. Okay, that's actually very good for a trial. And in real life, it may not be quite as good. Some of the patient characteristics here, these look like a lot of the patients that we treat, primarily male. Mean age was about 71. The mean CHADS-2 score was 2.1. 2.1, so reasonable that most of these patients were on full anticoagulation. About 20% had stroke. Many of them were on baseline aspirin. We really don't have the creatinine clearance for this particular trial, unfortunately, but we will have for subsequent trials. So here's the data. Here's what it looked like out of the New England Journal article. So that's the months are on the x-axis. The cumulative hazard rate is on the y-axis. And if we blow this up specifically to the curves itself, you can see that warfarin and dabigatran 110 looked pretty much the same, pretty much overlapping. Maybe slightly better after about 24 months. But dabigatran 150 ruled the day. And if you looked at this for the hazard ratio was about 0.66 with the number needed to treat of 172. This not only was not only non-inferior, it was also superior for the 150 and non-inferior for the 110. And so if you look at the major endpoints, breaking this apart even further, looking at stroke and then safety, the major bleeding, you can see that the stroke and embolism is significantly reduced. The major bleeding, no significant difference. And then if you break this down even further, you can see that really where the benefit is not necessarily an ischemic stroke, not statistically significant, but really the benefit was in hemorrhagic stroke. A very interesting finding. So is this a decrease in the bleeding risk, that is maybe the time to therapeutic level? They were too high at those times. Or was this hemorrhagic conversion? It's a little hard for us to tell. But suffice to say that what was really carrying the day was the hemorrhagic stroke. GI bleeding tends to be higher, and actually within this particular trial was significantly higher. And we also saw a trend towards decreased mortality within this trial from use of dabigatran 150. I don't show the 110 data because that's not currently available, so it's a bit of a moot point, although the trends were similar. And with this, they actually updated the ACC AHA recommendations such that dabigatran is now a useful alternative to warfarin in those patients, and basically describe the trial, that those patients with paroxysmal permanent atrial fibrillation, risk factors for stroke or systolic embolization, etc. But be careful with patients with renal failure. So I'm going to move on to Xarelto, also known as rivaroxaban. And this is going to be one of our series of patients, series of drugs that are competitive 10A inhibitors. So this is a little more bioavailable, about 80% bioavailable versus the 3 to 7%. It's not a prodrug. It's actually absorbed and is effective. Peak effect is about 2 to 4 hours. It's excreted in urine and then broken down by the CYP3A4 and then the 2J2, primarily a 3A4 mechanism. So that means that about 80% of the medications that are out there are going to be affected in some way or interact in some way with this one. So the dosing right now is 20 milligrams a day, although that may be changing to BID at some point, I'm not sure. And then there is a decreased dose if your creatinine clearance is between 15 to 49. Very similar to what we'd seen previously. So here comes the Rocket AF study design. And this by far has the coolest name of any of the trials so far. But it's about 14,000 patients and randomized to warfarin, again, INR target of 2 to 3, and then rivaroxaban 20 milligrams. And then a very small component of those patients actually had 15 milligrams. The duration was 1.6 years. And this is a tough trial because they actually report it in 2 different ways. So the epidemiologist in me started to have a little shudder as they reported the on-treatment results as the primary results. And so the New England Journal didn't buy it, neither did the FDA, so they made them report the intention to treat, which is the right way to do it. Right way to do it. I'm going to only show the intention to treat. So if you go into the New England Journal article, you say, well, why are these different? There's a reason why. It's because the epidemiologist in me says we have to do it this way. Endpoints very similar: stroke and systemic embolization, and safety endpoint of major bleeding. Here are the inclusion factors. They had to have prior stroke, TIA, or embolism, or greater than 2 risk factors of CHF, hypertension, age greater than 75, or diabetes. They were really looking for very high-risk patients in this particular cohort. And their goal was they were going to have greater than 90% with greater than 2 risk factors, really high risk. Again, powered as a non-inferiority warfarin. The time in therapeutic range was 55%. Anybody remember that number before? That's reality, but not in a trial. Not in a trial. Most of the other trials are in the 60s. And then they reported the on-treatment as well as the intention to treat. Some characteristics very similar to what we had seen before, mean age of 73. Males, sorry, I apologize if these are actually flipped. Males are actually 60%. I should have said female. CHADS score in this case was 3.5, significantly higher than what we had seen previously. So these were much higher risk cohorts. And so what's going to be reflected is the prevalence of disease and the event rate as compared to the other trials. Looking down, you can see that prior stroke and TIA now almost a little over 50%. Many of them were on aspirin. Warfarin naive was a little bit lower. The mean creatinine clearance, however, was 67, so pretty good. So here's the intention to treat data, looking at warfarin versus rivaroxaban, looking at the event rate per year, but this is per 100 patient years. So trying to compare this directly to the other trials makes it really hard. So I try not to, just broad strokes when you're trying to look between the trials. But looking at this, the hazard ratio is now 0.88. Non-inferiority was significant, but superiority was not for rivaroxaban versus warfarin. If you did the on-treatment, rivaroxaban was superior. Major endpoints, again, with a decrease in stroke and embolization. Major bleeding was no different. And then if we look again, some similar trends, although slightly different. Hemorrhagic stroke, again, carried the day. No difference in ischemic stroke at all. Major bleeding was slightly higher with rivaroxaban, but not significantly so in any way. GI bleeding was higher, mortality lower. So you can see that we're starting to see some patterns as we move through these novel anticoagulants. So this is the highest risk patient cohort. A little bit hard because, as I said, the data were expressed on treatment as well as per patient year. So extrapolation from trial to trial is difficult. But we were seeing some things which were really quite good. Again, that lower hemorrhagic stroke, a little higher GI bleed, which you'd seen before, and the trend towards lower mortality. Finally, we'll talk a little bit about Apixaban. And this was recently FDA approved for atrial fibrillation. Actually, I hear that the sales force is currently in Orlando learning how to penetrate our offices. No, but they're actually getting warmed up. And so within the next couple of weeks, the sales force is actually going to hit the road, if you will. And I haven't had a chance to figure out when Apixaban is going to arrive at the University of Washington. Not currently here. Walgreens is currently the only place you can pick it up, as far as I understand. But it is out there. It is a competitive 10A inhibitor, as we said before. Bioavailability is really quite good. Peak plasma levels around 3 hours. So really not substantially different than the others. And again, metabolized in liver, CYP3A4, and also some CYP-independent mechanisms. So this tends to be a little bit less renal dependent, but still you have to be a little bit careful. Now the dosing is 5 milligrams BID. What they found when they did a cost proportional hazard model, trying to figure out who the patients are that were actually having an increased bleeding risk, they came up with these risk factors. And so this actually carried into the FDA such that if patients have greater than two or greater risk factors of low body weight, less than 60 kilograms, creatinine of greater than 1.4 or greater than equal to 1.5, or age greater than 80, they have 2 of those, they should be on a lower dose, a half dose of the Apixaban, so 2.5 milligrams BID. This is going to be something that's probably not going to stick in your brain initially, but it's something that you may have to revisit. And this, again, was based on a couple of different studies. I'm going to show you 2 studies based on Apixaban, because this one actually highlights something a little bit different than what we've seen so far. It's something called the Adherence study, also published in the New England Journal. 5,599 patients. Was a randomized controlled trial in patients that were unsuitable for warfarin. Now, lots of reasons why they were unsuitable, including, I think they're not suitable. Okay, but But the trust is that, clinicians are pretty good at figuring out who's going to be unsuitable and who's not, right? There's no frailty index in the HAS-BLED index, right? So there was an assumption that there was a reason, but you had to give a reason. There's the very, very long, lengthy table in the article that I won't go into, but you can look at that. Some of them look pretty reasonable. Some of them look, honestly, a little fluky. But the point is that there are lots of reasons why these were unsuitable patients. Compared to aspirin, 81 to 324, this was a choice by the clinician to be anywhere between 81 to 324, so they had 1 to 4 tablets per day, as compared to Apixaban, and then, again, they had that high-risk criteria, which they had identified by this point. The duration ended up being 1.1 years because it was actually stopped early for benefit, intention to treat, similar primary endpoints, and safety endpoints. So here were the inclusion criteria, which were greater than 50 years with atrial fibrillation within 6 months, and greater than one of these risk factors that you see over in the blue box: stroke, CHF, greater than New York Heart Association 2, hypertension, age greater than or equal to 75, or diabetes. And this was powered as non-inferiority aspirin. So here's the data. So if we took at stroke and embolism, actually had one of the highest hazard ratio improvements with a decrease of about 55%, and very statistically significant. Interestingly, in this case, the trend towards hemorrhagic stroke was there, but this time, when you compared aspirin versus this drug in patients that were otherwise not candidates for warfarin, significant improvement in ischemic stroke. Significant improvement in ischemic stroke. So once we accelerate from antiplatelet to full anticoagulation, those patients now do better with ischemic stroke. This is not too surprising, but good to see. The most interesting part is what happens with the balance. What happens with the major bleeding risk? Because that's the reason why we're not doing anticoagulation in these patients. Major bleeding risk, no different. GI bleeding, no different. Mortality trended towards benefit and actually was almost there at 0.07. So this is kind of a game changer a little bit in that because we don't have these problems with warfarin, and probably because of the labile increases in the INR, that in this particular trial we were seeing an equivalence of major bleeding with benefit in ischemic stroke, such that we may be able to take that intermediate risk, the moderate risk category, and say maybe those patients would be more appropriate for full anticoagulation rather than just aspirin therapy, and it's safe to do. So because of this, we're going to see how this manifests as we go along. I think probably within the next 2 to 3 years, we're going to see an update within the ACCHA. It may actually be sooner than that, given the amount of data that we have with the multiple agents. But we could see that that moderate risk category would be something like anticoagulation with the novel anticoagulations is now preferred rather than an option. So we may actually have something that would be changing some of the ways we approach it. Now, looking at the more classically designed study of ARISTOTLE, which is Apixaban versus warfarin, another 18,000 patients. I mean, how many thousands of patients have we just seen? Apixaban versus warfarin, duration of 1.8 years, very similar primary endpoints as well as safety endpoints, and again, non-inferiority, and then asking if it's superiority in a hierarchical fashion. So very similar, again, age about 70, mostly male. CHADS-2 scores 2.1, very similar to what we saw in RELY. Stroke is now significantly less than what we saw because it's not an entry criteria in ROCKET-AF. And then baseline aspirin about 31%, and not quite 50% were warfarin naive. Creatinine clearance, unfortunately, wasn't available, the actual number. But we do know that 83% were greater than 50, and most of them were greater than 60. So here are the curves, looking at the months on the x-axis, the percent with event on the y-axis, and looking at the relative risk reduction. The hazard ratio is 0.79. It was non-inferior. It was also did get inferior with a p-value of 0.01, but the number needed to treat was 303. So these were a little bit on the lower risk, so the number needed to treat was slightly higher. Looking at the major endpoints again for stroke and embolism and major bleeding. In this case, the major bleeding, rather than being similar, actually was statistically less. And similar for stroke and embolism. Again, hemorrhagic stroke carried the day. GI bleeding, though, in this case, rather than being increased, actually was no different. And that's the first time that we've seen this within these trials. Mortality actually just barely made significance with a p-value of 0.47, but again, another trend. So what is the net benefit of these novel anticoagulants, kind of putting this together? Well, if looking at a meta-analysis that was recently done, right, because the first thing that happens is that it gets published in the New England Journal. The next thing that happens is 3 weeks later, somebody comes out with a meta-analysis, right? So I think there are 4 or 5 meta-analyses. This is the one that I like in Circulation, taking the 12 phase 2 and phase 3 studies, about 54,000 patients. I'm going to make very broad strokes, lumping all of these together. There are some issues with doing that, but just take some broad strokes to make some points. First off, we're seeing on average a stroke and systemic embolization decrease of approximately 33%. The relative risk of 0.77, number needed to treat of about 135. Major bleeding decreases by about 14%, number needed to treat 156. And then total mortality actually was statistically less. We saw all of those trends. Once you put them together, we do see a decrease in total mortality, although arguably you have to treat a lot of patients this way in order to find that. And these are all compared to warfarin. So just by switching to the novel anticoagulants, we're seeing substantial improvement and no difference in major bleeding. So what are some of the concerns that we have in the last few minutes as far as these anticoagulations? One of which is discontinuation. How do you do that? What are some of the concerns about that? What about drug reversal? Some of the drug-drug interactions we've talked about, and I'm going to spend very little time on that, as well as renal dysfunction. Well, as far as discontinuation, we do worry a little bit about this. We don't understand these drugs as well as we'd like, specifically for rebound. And that is that if you stop the medication, what happens? Is there a prothrombotic state that occurs briefly? Right now, there are 2 black box warnings, one for Apixaban, one for rivaroxaban, that if you stop in those patients with high risk for stroke, you do need to bridge with another anticoagulant. That's currently the black box warning. This may be one of those things like, well, if they're high risk, they probably still remain high risk, whether or not they're on or off anticoagulation, so it's probably a pretty good idea. But the relative risk for the brief periods of time that you would be stopping them for procedures and things we'll talk about in a second. If the patient misses a dose, you take it as soon as possible. There's really no recommendations other than DABI, which says if it's within 6 hours of your next dose, don't bother. But otherwise, they do suggest that you take it again as soon as possible. The 6 hours seems fairly reasonable for most of the other agents. What do we do about paraprocedural management? Important for people in this audience when you're doing the pre-op evaluation. And there are some recommendations within the product inserts. So for Apixaban, they suggest that it's you stop greater than 48 hours before surgery at moderate to high risk of significant bleeding. And then you can stop if it's within 24 hours as a low bleeding risk. If it's DABI, then you want to stop 1 to 2 days if the creatinine clearance is greater than 50, 3 to 5 days if it's less than 50 for surgery or procedures. And then finally, for rivaroxaban, they say greater than 24 hours before surgery or procedures. Okay. So fairly similar. Obviously, if they have renal dysfunction, you want to be careful of those patients because you're going to hold on to it longer. But otherwise, relatively similar. What's the biggest problem with these? Biggest problem is reversal. Your patient comes in, they do have that intracranial hemorrhage. What are you going to do with them? You know, one of the things that I do whenever I start one of these patients is we have a little conversation. We have a little bit of conversation about the good and the bad, and this is the bad. And so if they come in and they're on one of these agents, sometimes you just light a 12-hour candle and then hope they make it through, and by the time the candle burns down. That's about the time that most of this should have worn off. But there's currently no reversal agent. That being said, right now we, particularly at the University of Washington, actually have some agents which may work. There's prothrombin complex concentrate, or recombinant factor 7A, which have been used successfully in healthy people. And actually the reversal is rather profound in those healthy people. However, there's no data in patients that are actually bleeding. And the problem is how many patients, or sorry, how many centers actually have recombinant 7A sitting on their shelves, right? Why do we? Well, we're the University of Washington. We have this wonderful thing called the HUDGE. And so we have, lots of these things. There may be some other agents out there that could do this also that have been used for hemophilia, but really only tested in healthy individuals, so more data are needed, and those data are actually being acquired. So if you're really in a bind, you can try that. So for DABI, there's really no reversal agent at this point. There is an antibody that's currently in phase 2 trial that's being worked on. There's another one that's being developed down in San Francisco for actually all of these agents, but really nothing right now. Now, DABI is dialyzed. You can get about 60% off of it in 2 to 3 hours. However, remember that I said that it binds the free DABI as well as the bound DABI, right? So whatever's bound obviously isn't going to get dialyzed off, so we do have to worry a little bit about that yes, we may dialyze it off and have virtually no effect. So we do have to worry about that a little bit. So the patient benefit is really unclear, and the couple of case reports that are out there, we don't seem to see a whole heck of a lot of benefit right now, but that's it. We're really at a case basis at this point. So what can we measure? Well, we don't have a lot to measure. We can't really measure anything to know whether or not it's therapeutic. We can measure whether or not it's there by doing something like an APTT for DABI or PT-INR for rivaroxaban. So we can measure that they exist, but we can't measure how therapeutic they are. So this is a problem. So those tests are also being developed, but currently we don't have anything, especially if our patients are coming in bleeding. What about renal function? Well, renal function, obviously, I've been saying a lot about renal function for a good reason, because we're concerned about that for these patients. That stroke and bleeding risk is really inverse to renal function to begin with. And then if we look at the efficacy specifically, within the ROCKET-AF trial, high-risk patients, look at the creatinine clearance of greater than 50 and the creatinine clearance of 30 to 49, essentially comparing 20 milligrams versus 15 milligrams, no significant difference. The tester heterogeneity was negative. And so really no difference in those patients. What we don't know is what about patients that develop renal dysfunction? Our CHF patients that come in with decompensated CHF, increased renal function, increased creatinine, decreased renal function. What do we do with those patients? It's a little bit unclear right now. It's a little bit hazy. As time goes on, we're going to know better and better how to treat those patients, and maybe avoidance of those patients, at least for the short term, might be reasonable. Those patients you really know are going to be quite labile, the class 3, class 4 heart failure patients, significant systolic dysfunction, etc. So in the last minute or two, I'm going to take a look beyond atrial fibrillation, looking at warfarin. Why haven't we been using warfarin? Because warfarin is actually shown to be beneficial in significantly decreasing major adverse cardiac events. And if you go back to some older data, and this is actually data that's put together looking at mortality, myocardial infarction, death, myocardial infarction, stroke, etc. Once you put all those together, you actually have a relative risk reduction between 16 to 42% in those patients that are on high-intensity anticoagulants as compared to control. And even when you compare it to aspirin, there's still a significant improvement in major adverse cardiac events, things you'd like to avoid. Why haven't we used it? Obviously, the bleeding risk is very, very high, and so we do have to be, so warfarin has not been used regularly. Well, they tried to say, well, what about, since bleeding risk is less, why don't we try to apply our new agent to acute coronary syndrome? And this was done in something called the ATLAS trial. And they looked at ACS, and they had this, large combined endpoint of death, MI, stroke, severe ischemia requiring revascularization. And there was a trend towards a decreased risk using rivaroxaban versus placebo. But if you looked at the bleeding, it increased substantially as you went from a low dose of rivaroxaban, 5 milligrams, up to 20 milligrams. Not too surprising, right? More anticoagulation, more bleeding. But because there was no significant improvement in outcomes and the bleeding was higher, rivaroxaban is not currently indicated in ACS, and the FDA turned it down for that indication. Well, what happens if we apply this to maybe a less high-risk patient population? where you're not using things like dual antiplatelet therapy and then adding anticoagulation on top of it. And that's something called the COMPASS trial. We're actually the co-country coordinators for the COMPASS trial. They're going to be approximately 19,500 patients, probably 20,000 after all is said and done. They're going to be comparing placebo, rivaroxaban, in 2 doses, low dose, in patients with chronic coronary artery disease, peripheral vascular disease, as well as risk factors. There's also going to be an aspirin component, including an aspirin placebo component, where you're taking only active rivaroxaban for it's only active rivaroxaban. The expected duration is approximately 3 to 4 years with an endpoint of stroke, myocardial infarction, or cardiovascular death. So I'm actually the local PI for this. I'm also the country coordinator. So this is something that you may hear me harping on as it goes along. In the next 3 or 4 years, then maybe I'll be back on the podium to show you how wonderful this is or how disappointing this was when it was stopped early, right? I don't actually know. But suffice to say that the idea is that we really want to move the envelope and move it further to try to figure out whether or not something like oral anticoagulation is now safe enough from a bleeding standpoint such that we can use it in lieu of aspirin to help our patients even further. So there are safety endpoints. There's actually a PPI component that goes within this. It's actually pantoprazole that's going to be used. We're going to have approximately 50 patients here, and we're going to be responsible for about 2,000 patients of the 20,000 specifically within the United States going through PHRI. So in summary, novel anticoagulants, they do compare very favorably to warfarin, and actually in many instances do better. There's lower stroke and embolism, especially with hemorrhagic stroke. There's possibly less bleeding overall, especially if you take the broad brush and apply it to all. 3 agents are currently, there will be 2 more, and once competition comes in, then we will see whether or not the cost actually goes down, although this is currently a major issue. Reversal agents, whoever gets the reversal agent wins this battle, at least wins this round and a very significant round. So we're waiting. Once that happens, that's actually going to be a coup, or we prove that what's already on the shelves we can use and then becomes widely distributed. Be careful with the drug-drug interactions that we talked about, renal function, then really patient selection, just like anything else, becomes very, very important. So is warfarin's lifespan limited? Probably. In most, but not all patients. There are still some patients where warfarin may actually still be reasonable, and specifically in those patients with impaired renal function. And then finally, further data such as COMPASS and others are pending. So thank you very much. I'll have a couple minutes for questions, and I appreciate you having me.